Hello, my name is Dr. Philip Mease, Director of Rheumatology Research at Swedish Providence Medical Center in Seattle. I've just returned from the EULAR meeting in Barcelona, which was chock full of interesting and important data on the various treatments that we have for rheumatic disease, including axial spondyloarthritis. And I'd like to discuss some of the take-home messages around interleukin-17 inhibition in axSpA. As you know, we have a limited number of treatments that are effective in the spinal inflammation of axial SpA. The TNF inhibitor class is effective. The IL-17A inhibitor class is very effective. The JAK inhibitor class is effective. But then it stops, and we don't have other classes of medications that are shown to be helpful. So we saw at this meeting long-term efficacy and safety data with the IL-17A and F inhibitor Bimekizumab. As you know, one of the key pro-inflammatory cytokines in diseases like axSpA, psoriatic arthritis, psoriasis is IL-17A. But we're also learning in recent years that IL-17F, another member of the IL-17 family, is an important pro-inflammatory cytokine as well. So in the presentations at the meeting, we saw data out to 3 years on the B-Moving study. B-Moving is the open label extension of the B-Mobile 1 study of bimekizumab in non-radiographic axial spondyloarthritis. And B-Mobile 2 is the original phase 3 trial on the radiographic axSpA patient population or ankylosing spondylitis. And then patients were eligible to move into a long-term open label extension study called B-Moving. We saw 3-year pooled efficacy and safety from B-Moving, for example, showing an ASDAS of less than 2.1 in 60% of patients. ASDAS is a preferred outcome measure in axial spondyloarthritis. It has an objective component, i.e. a CRP, as well as subjective elements. And in our clinic, we actually do measure this, and it's a goal of treatment for our patients to get less than 2.1, which would be considered low disease activity, and less than 1.3 is remission. So as mentioned, we saw 2.1 or less in 60% of patients. There was also MRI assessment, which showed that more than 59% of patients achieved a SPARC sacroiliac joint MRI remission, and over 77% had Berlin spine MRI remission. In a separate poster, we saw data on important patient-reported outcomes, such as improvement of spinal pain, less than 4 in 60% of patients, improvement of FACIT, a fatigue measure, greater than 8 in 55% of patients, an improvement of the functional score of less than 4 in 2/3 of the patients, and a 4-point or more improvement in the quality of life measure, the ASQUAL, in 2/3 of patients. So this is really solid data showing efficacy out through 3 years. We also saw an interesting study that looked at efficacy data as segregated by sex, male versus female. One of the reasons this is interesting is that in recent times, we've been seeing that in some of the biologic studies, males have better responses than females do. And this was indeed the case when the data was analyzed at week 16 from the B-Mobile 1 and 2 pooled studies. But when you went out to week 52, the results were similar. So this is actually reassuring for the female population. From a safety perspective, we really didn't see any new signals. There is a small incidence of Candida, which tended to be very easily treatable. We know this could be a side effect because IL-17 helps protect us from surface Candida. Also, there were a small number of cases of inflammatory bowel disease recurrence or new onset. One of the other interesting observations was regarding uveitis. Uveitis flares are captured as adverse events in these clinical studies. And one of the things we know about axSpA patients is that there is a tendency to have this associated condition, uveitis. In a previous set of studies, in the placebo-controlled phase of the B-Mobile 1 and 2 studies, it was shown that the patients in the Bimekizumab treatment arms versus the placebo arms who had uveitis prior to coming into the studies had observations about uveitis after being on one of the treatment arms, and it was found that there was much less likelihood of having a uveitis flare in the Bimekizumab treatment arms as opposed to the placebo arms, which is an interesting observation. We don't really know whether or not Bimekizumab can effectively and beneficially treat uveitis, but at least it doesn't seem to promote it. And this is data that may support the fact that it can help prevent uveitis flares. Now, at this meeting, we saw a pooled long-term analysis, 2,500 patient-year observations in axSpA and 3,600 patient-year observations in PSA. And in the total population of axSpA patients, there were 1.3 events of uveitis per 100 patient years, and in psoriatic arthritis, 0.1 events in each year. And in a risk population of patients with a history of uveitis, these numbers were 4.8 and 2.4 respectively. So at least we're not seeing a large number of uveitis cases. This is very low. So all in all, this is further data that supports the use of IL-17A and F inhibitor, as well as the previously reported data sets on IL-17A inhibition as an important therapeutic agent for treatment of axial spondyloarthritis. For more information and more details and highlights from EULAR in Barcelona, head on over to Room Now.